Okay, I think we'll get started today. So thank you to all of you for joining us again for our monthly virtual seminar series. For those of you who don't know me, my name is Kelly Metcalf, and I'm one of the scientists here at Women's College Hospital. And we're thrilled to be able to bring you some of the latest research that's happening in the area of hereditary cancers. So most of you, if you've been joining the seminar series, will know our speaker for today. She's my partner in these seminar series, Dr. Joanne Kotsopoulos. She is a professor in the Dalla School of Public Health at the University of Toronto and a scientist here in the Hereditary Cancer Unit at Women's College Hospital. So Joanne, I'll just get you to share your screen. And I'll just remind everyone that if you have a question, please remember to put it in the Q&A, and you can type those as we go along. And then at the end of Joanne's talk, I will ask the questions that you have put in the chat, and we can get some of the answers to the questions that you may have. So this is also being recorded. So if you have others who you think may benefit from hearing this seminar, please direct them to the website and they'll be able to find this recording in the next couple of days, possibly week. But all of our previous seminars are there as well. So I think I will turn it over to Dr. Kotsopoulos, and then we will take some questions at the end. So thank you.
Thanks, Dr. Metcalf, and thank you everyone for joining us over this lunch hour. So this is our last session before our summer break, and we will be returning in September again. So like Dr. Metcalf had mentioned previously, we're trying to provide some sessions based on the feedback we received from from our attendees. And there were quite a few questions about reproductive and hormonal factors and the impact on BRCA-associated cancer. So I'm going to try to give you a little bit of an overview of what we know so far. I always like to start off with the cancer risks and clinical management of hereditary cancer. And I know this might be redundant, but just for those who might be joining for the first time, I'll give a really brief overview. I'll introduce some of the important reproductive factors that may be influencing risk. And I'll also talk about hormonal, and I've also included anti-hormonal factors because there is a role of some chemoprevention agents like tamoxifen, which actually block estrogen. And then some summary and next steps on the kinds of studies that we're hoping to keep conducting and reporting on. So we know that for the management of hereditary breast cancer, there is a very important role of MRI imaging and mammography. Of course, risk reducing or bilateral preventive mastectomy is really the most effective way to prevent hereditary breast cancer, but of course is associated with some disfigurement and is a really important decision to be made and is a very personalized decision. Then there is an important role of risk reducing agents such as tamoxifen, and I will be presenting some of that data later on. When we talk about ovarian cancer, we see that when we look at the recommendations, it's strongly advised that women with the BRCA1 or 2 mutation undergo bilateral oophorectomy. And there are age-specific recommendations depending on what mutation you carry. And so it's advised that women with the BRCA1 mutation remove both the ovaries and fallopian tubes before age 40. And the ages of surgery is a little bit later for BRCA2 mutation carriers and currently recommended between age 40 and 45. Currently, salpingectomy alone, so removing just the fallopian tubes and leaving in the ovaries, is not standard of care. And unfortunately, unlike the management of breast cancer, there is no effective screening options to detect ovarian cancer at an earlier age. And this is why preventive surgery is very important. So all the data that I'm presenting continues to come from our large study called the Risk Factor Analysis of Hereditary Breast and Ovarian Cancer Study, or Risk Factor for short. Many of you contribute to this study, and this is very important to our team. And this is how we're able to conduct some of these large analyses that Dr. Kelly Metcalf and Dr. Nerod and I often present at these seminars. And for some of you that may not be participants, the way this study works is that women complete a questionnaire at the time of enrollment, and then we follow women over time every 2 years to collect detailed information on various factors such as surgery, hormone use, and other important events. And so to date, we have over 18,000 women enrolled. This is really important, and it's become the key infrastructure for our team. And we thank all participants who continue to provide this data to us. So first, I'm going to introduce some of the data regarding the role of reproductive factors. And so when we look at the literature for women who don't have a mutation, so women in the general population, we know that there's an important role of various reproductive factors. And so we've also taken a look at some of these factors, specifically mutation carriers. And so I've summarized some of the key studies and just the key findings with arrows or lines indicating no association. And so when we look at age at menarche, or the age at which a woman first gets her period, this is associated with a decreased risk in BRCA1 mutation carriers, but has no impact in BRCA2. Childbirth, so having a baby, or age at first birth, currently does not seem to play a very important role in influencing the risk of breast cancer and mutation carriers. However, what we do see is a strong protective effect of breastfeeding, and this is observed in both women with the BRCA1 or 2 mutation. And this is also similar to what we see in women who don't have a mutation. So when we talk about cancer risks in BRCA1 and 2 mutation carriers, we always have to look at the impact on various factors, also on ovarian cancer. So again, I've summarized some of the key findings. Age at menarche also decreases risk in BRCA1. So this is ovarian cancer risk. Childbirth decreases the risk in BRCA1, but has no impact on BRCA2. And what's important is that we see an important role of breastfeeding. It's a significant protective reproductive exposure in women with a mutation, with either mutation, and also decreases the risk. So I've shown you that it decreases the risk of breast cancer, but also decreases the risk of ovarian cancer. Age at first birth doesn't seem to have a big impact. But often when we talk about ovarian cancer, we think about ovulatory cycles. So how many times a woman has a menstrual cycle over her lifetime. And a lot of the factors that I've summarized here actually are taken into account when we estimate a woman's lifetime ovulatory cycles. So it's clear that some of these factors are likely impacting a woman's risk by preventing ovulation. So when a woman is pregnant or breastfeeding, she's often not ovulating. And so the lower the number of ovulatory cycles, it seems to be associated with a lower risk of disease. So those are some reproductive factors, some of which are modifiable and some of which are not. Most importantly, breastfeeding is something that all women can do or may be able, so I shouldn't say can, may opt for after they've had a child. But we also think about anti-hormonal or hormonal exposure, such as contraceptive use, hormone replacement therapy, and also chemoprevention, which are anti-hormones, such as tamoxifen. So we have actually very recently looked at the impact of tamoxifen on breast cancer risk in women with a mutation. And tamoxifen is an option for women who do have a mutation. And this has really been historically based on data from non-carriers. And there were no large trials or prospective studies that exclusively looked at women with a mutation. What we do know is that chemoprevention or tamoxifen use is quite low in mutation carriers. So we don't know if this is because healthcare providers don't recommend it, or because we don't really have conclusive evidence from studies that have been performed in women with a mutation. And so we very recently actually had this paper, will be published shortly, looked at the impact of tamoxifen. And so if you remember to my earlier slide, I said that there were over 18,000 women in our cohort. When we looked at how many women were potentially eligible for this analysis, we found that there were only 202 women who had used tamoxifen or raloxifene. So these are similar drugs that inhibit estrogen from binding. in our bodies, we found that a very small proportion of women with the mutation actually use tamoxifen. So right away, we're seeing very low usage. And when we looked at the proportion who developed breast cancer in women who did, so exposed or did not unexposed use tamoxifen, we don't see a very striking difference in the proportion who used it. So about 11% developed breast cancer in the women who used tamoxifen and 14% in the women who did not. But when we conduct our statistical analyses, we always have to account for other factors that may be important, like age, menopausal status, and other factors. So then we conducted a larger analysis, a more robust analysis. And when we take into account these factors, we see that there might be a protective effect of tamoxifen. We're seeing a perhaps 38 to 40% reduction in risk. Unfortunately, we cannot conclude at this time if this is a significant or statistically significant effect, but we are seeing a reduction in risk. And so there's two issues with this, is that not a lot of women were taking tamoxifen, so we weren't really statistically powered. Another issue is that we don't know if more women will continue to use or whether we'll be able to conduct any larger analyses unless we see an increase in usage. Again, we have to think about tamoxifen and the risk of ovarian cancer also, because in non-carriers, tamoxifen may increase the risk of ovarian cancer. We did take a look at this several years ago. Again, I won't expect you to look through all this data, but when you see a hazard or odds ratio below 1, that means it's protective or not a harmful exposure. And so we saw no relationship between tamoxifen and ovarian cancer risk in mutation carriers. So this means women who opt to use tamoxifen to potentially prevent their breast cancer shouldn't be worried about it increasing their ovarian cancer risk. So something that is quite important for especially a younger mutation carriers is whether oral contraceptive use will increase her risk of breast cancer. And again, this presents another conundrum because we know that in carriers and in non-carriers that oral contraceptives significantly protect against ovarian cancer, but may increase the risk of breast cancer. And we have shown this in historic studies performed by Dr. Narod in the late 90s and early 2000s. And there was a meta-analysis, which means authors that took all the existing data and pulled it together to see if we could come up with a more conclusive suggestion. And unfortunately, this snapshot here, which looked at all the data, shows that there probably is an increasing risk with oral contraceptive use. But there are still a lot of unknowns, and this is why we're undertaking a large collaborative study to really understand which type of contraceptives, duration of use, timing of use, and whether this is a significant risk factor for BRCA-associated breast cancer. But similar to what we see in non-carriers, oral contraceptive use usually increases a woman's risk of breast cancer at the time of usage, and usually will go away after a woman has stopped using it. So it's a very transient increase in risk. But we're trying to confirm that this is also true for women with a mutation. So in this meta-analysis, they also reported what we had shown previously, that oral contraceptive use is associated with a 40 to 50% reduction in the risk of ovarian cancer in mutation carriers. So it's a dose-response relationship. It's stronger with more recent use. And what's important is that this protective effect of ovarian cancer persists even when a woman stops using it. So after preventative surgery, this appears to be the strongest protective factor for high-risk women at risk of ovarian cancer. And so there was a recent paper published really talking about this conundrum, this fact that, mutation carriers have a lot of decisions to make, and we have to take into account the breast cancer and ovarian cancer risk and really take a personalized approach to exogenous hormone use. So it's why it's important for mutation carriers to continue to discuss with their clinicians what kind of additional risks they're willing to take. So women with a BRCA mutation are at a high risk of both breast and ovarian cancer. Most are opting for preventive oophorectomy at the right time. There is potentially a small increased risk of breast cancer, but women should continue to discuss what kind of risks they're willing to take, and really that the mutation itself is associated with the highest risk of disease. So maybe they can still take oral contraceptives for a short duration. So what about contemporary or other hormonal contraceptives? We know that there's been a changing landscape in the type of contraceptives that are being used with the introduction of IUDs, an increase in use of IUDs, hormonal IUDs such as Mirena. And we also know that there's a lot of other non-oral contraceptives that exist. And this has really not been evaluated as much in both carriers and non-carriers because these are contemporary hormones and there hasn't been enough follow-up time to see if this type of contraceptive impacts cancer risk. So one of our recent graduates did take a look in our database to see if these other contraceptives also protected against ovarian cancer and mutation carriers. So this included implants, injectables, and IUDs. And she also reevaluated oral contraceptive use. And what we see that in this analysis, the odds ratios are all below 1. That means we're showing a protective effect with the use of any type of contraceptive. However, again, we were not statistically powered because many of these are newer types of contraceptives, or as we can see right away, most women still continue to opt for oral contraceptives. What was reassuring is that the IUDs and injectables and implants were not harmful, but they were likely associated with a decreased risk. So those were more the contraceptives, but in a woman who has undergone an oophorectomy or entered menopause, we really need to think about the impact of hormone replacement therapy and breast cancer risk. And we conducted this analysis in 2016, and we're currently looking to replicate it or redo this analysis with additional follow-up time to look at whether using hormone replacement therapy after a woman had a preventive oophorectomy increased her risk of breast cancer. Because we know that women are opting to remove their ovaries. This surgery is preferably performed at an early age. So we really need to think about not just preventing cancers from happening, but also ensuring we're not causing harm, we're not causing a declining quality of life and other factors associated with oophorectomy. So there's an important role of using hormone replacement therapy in these women. So this plot here shows us the incidence of breast cancer in women who did and did not use HRT. So right away, we see that these lines are very similar. So it seems that when we look at any HRT and no HRT use, we didn't see a big difference in the incidence of breast cancer after 10 years. But when we stratified by estrogen alone use versus estrogen and progesterone, we saw that there was an increased risk of breast cancer with estrogen and progesterone use versus estrogen alone. And this is similar to what we've also seen in trials conducted among women in the general population who do not have a mutation. We also looked if the effect was stronger in women who had an oophorectomy at a younger age, and we did indeed see this. So estrogen alone, to put this into context, the risk of breast cancer was similar to the never HRT users, but there was a higher risk in the estrogen and progesterone users. So when we think about this, this brings up more questions actually, because estrogen alone is provided to women who have had a hysterectomy or do not have a uterus, whereas estrogen and progesterone is given to a woman who has an intact uterus, so who only removed her ovaries and fallopian tubes. So this also brings up the question of whether women with the mutation need to be removing their uterus at the time of oophorectomy, because that hasn't been decided yet, and it's really a personal decision. And also, there's interest in other types of hormone replacement therapies that could potentially be used instead of the estrogen and progesterone or estrogen alone. And so there's still a lot of work to be done here. But of course, if a woman has had a mastectomy, this is not anything she needs to worry about. HRT does increase the risk of ovarian cancer in non-carriers. This is a pretty old study in 2006. Also, we're thinking of replicating now that we have more follow-up. But in this initial follow-up study, we did not show an impact of HRT on ovarian cancer in carriers. So now I'm going to switch gears and talk about fertility treatment. I am not going to provide too much information because Dr. Karen Glass, who is an IVF specialist and really does a lot of work with high-risk women, has presented several times with our team, as she provided her own presentation and was part of our recent panel session. So feel free to go back and re-review her talks for a more, or her videos for a more in-depth look. But she also talked about one of these papers that we published that looked at treatment for infertility and BRCA cancer. And again, numbers are much smaller when we exclude women because you've had a previous history of cancer, and this is using our data. But our initial publications showed no real significant increased risk in women who either reported a fertility problem, who took fertility medication, or who actually received IVF for the treatment of their infertility. Again, these are observational data, and this is why it's important that we continue to enroll women and continue to reevaluate these studies. And again, like I mentioned many times, we always have to look at the risk of breast and ovarian cancer. And here we see that treatment with IVF for intrauterine insemination, we did not show a significant impact of these infertility treatments on the risk of ovarian cancer. So I've talked a lot about hormones and anti-hormones, but what about other modifiable factors? So there's a lot of talk about exercise and physical activity, and perhaps other sorts of drugs that we take for other conditions. And there is a lot of interest in these factors. And we have, as a team, looked at a lot of these factors. And I've tried to just provide a little summary here based on whether we found that these were risk factors, protective factors, or if they showed no impact on risk. And so, for example, we have shown that smoking, later age and menopause, weight gain, are associated with the risk of breast cancer. I talked about contraceptives potentially increasing the risk of breast cancer, but we know that mastectomy is the gold standard for preventing breast cancer, and there is a role for breastfeeding and physical activity. In an earlier report, we did look at alcohol consumption and saw no association with BRCA breast cancer. Again, for ovarian cancer, smoking is also a risk factor, as is weight gain. Some of these other factors we're going to continue to reevaluate now that we have larger sample sizes, such as fertility treatment, HRT, and talc, which has been in the news quite a lot for decades now, and the association between talc and ovarian cancer. Oophorectomy, bilateral sublingual oophorectomy, remains a gold standard to preventing ovarian cancer and improving outcomes in high-risk women. And there continues to be a role of contraceptive use and breastfeeding in preventing BRCA ovarian cancer. We've shown no impact of physical activity or alcohol consumption on risk. So just to summarize again, we know that the lifetime risk of breast and ovarian cancer is high in women with the mutation. We have important evidence-based guidelines to help a woman manage her risks and to make these personalized decisions. But it is a balancing act. It depends on woman's prior history, whether she's opted for screening, whether she's had a mastectomy or a oophorectomy or both. So this is why it's important for women to continue these conversations with their genetic counselors and clinicians. We've recently showed a very profound impact of oophorectomy on death. So not only does it prevent fallopian and ovarian cancer from occurring, it improves a BRCA mutation carrier's likelihood of surviving. So unlike women in the general population, early surgical menopause is associated with an increased risk of death, But in mutation carriers, it's the opposite. We're seeing a striking and profound impact on mortality. For those of you who are patients at Women's College or perhaps another high-risk clinic, it's really important to mitigate the adverse non-cancer outcomes following oophorectomy if you've had one prior to natural menopause. And again, aftercare clinics such as ours are an important place to continue to talk about your HRT and ensuring you're managing your symptoms, your bone health, and other outcomes associated with early surgical menopause. But just like you, there's so many unanswered questions that we're really trying to continue to answer. Some of these effects are seen in one mutation carrier and not the other. We're really trying to evaluate whether oral contraceptives impact the risk of breast cancer. Like I said, we're currently evaluating this in a larger international consortia. We're continuing to figure out the best way to manage menopausal symptoms, the safest way, and continuing to look for novel prevention options, such as aspirin and metformin. There's interest in the use of these other drugs as chemoprevention options. But again, larger studies are needed and additional follow-up is needed, and that's why we're continuing to do these analyses. But of course, this is a team effort by our scientists, genetic counselors, trainees, and research staff. We're a big team with a lot of collaborators, and a lot of work goes into these studies. And of course, our funding agencies, and most importantly, our mutation carriers who continue to contribute questions and data to us. So I kept this fairly short because some of it was a repeat, and I thought it would give us an option to discuss if there are any questions, which I don't actually see any in the chat box.
Thank you so much, Dr. Kotsopoulos. I think it's nice to see it broken down in the summary because there are always so many questions, and it is a difficult decision for women to be making. So there aren't any questions. So I just want to remind you that if you do have a question, please enter it into the Q&A, and then we will see it and we can answer those questions.
And just to reiterate, some of these factors that we look at, it's important to help us understand why mutation carriers develop cancer, what hormonal pathway might be involved, because although, for example, if we think of something like HRT, by knowing that estrogen and progesterone increases a woman's risk, we're able to contribute to the literature and understand potentially how we can identify other targets so that a drug could potentially target the same pathway to help prevent disease. So a lot of these studies may not be directly impactful, but do help in the contributing to the entire literature as a whole.
Okay, there's a question about the videos of the seminars. They are posted on the website, on the Women's College Hospital website. You can find those there. Please also let us know, you will be receiving an email to get feedback. Please let us know what other sessions you would like to see us. I see there's a question about BRCA in men. That is something that we have covered in a previous seminar. So if you want to go back and have a look at those, again, share those video links with whomever you think would benefit from watching those. But we have covered something, I think it wasn't specifically about men, but it was about other cancers. And we definitely covered some of the other cancers, male cancers in that seminar.
And I know there's some problems finding. We're trying to work on making it more accessible. If you cannot find the seminars, let us know. They are also in a YouTube context. If you really need to just Google one of our names, they should show up. Okay.
So there's a question about aspirin and the biochemical impact and how this drug may be used in prevention of cancer or risk reduction of cancer. So Dr. Kotsopoulos, do you want to respond to that?
Sure. So there's a lot of interest in some of, there's always been interest, not just for carers, for cancer in general, on how commonly used medications may impact cancer risk and survival. So we have a lot of drugs that are commonly used, like aspirin, metformin, statins, that have a lot of widespread use. And so because, for example, something like ovarian cancer, there's a lot of experimental studies showing that it's the repeated ovulation that happens every month that causes an inflammatory pathway. So this is very simplified. So it's not surprising that people would think an anti-inflammatory, so like aspirin or an NSAID, might also be a preventative agent, not only for ovarian cancer, but for other cancers that may be associated with inflammation. So there is some interest, and there's been a lot done in non-carriers in ovarian cancer, and there's some data to support aspirin as a prevention for ovarian cancer in non-carriers. But again, there is a small trial ongoing for carriers actually, but there's no data published yet. But there is an opportunity to use aspirin as a chemoprevention. Now, this has mostly been shown in non-carriers, so it's very premature to think that this may act, but we will be looking at agents like metformin and aspirin that act on these inflammatory pathways. I posted the link in the chat for the
Yeah, so if you just go into the chat button at the bottom, you'll be able to see the link that you can just copy and keep that link so you can see where the recorded seminars are. What about multiple risk modifiers? For example, breastfeeding and contraception and physical activity. Can you put it into context, especially if we're thinking about ovarian cancer, where the gold standard really is to have a prophylactic oophorectomy or the preventive removal of your ovaries and fallopian tubes? Will any of these modifiers ever get to the point where it's going to offer the same protection as removal of the ovaries?
So unfortunately, we would never replace the gold standard, which is preventive surgery, with any of these factors. These would be add-ons and things we look at that may be influencing risk until the time of surgery. So for example, a woman with a BRCA mutation might opt for surgery at age 45. We know that a few cancers could potentially develop earlier. So by breastfeeding or taking oral contraceptives, she might be at least reducing the risk until the time of surgery. That makes sense. So again, like Dr. Metcalf just mentioned, these are not meant to replace the gold standard. We know that, for example, for ovarian cancer, removal of the ovaries and fallopian tubes is very important and is strongly recommended to all women with a mutation. But these are also important things to consider. Unfortunately, there are some women who opt not to have surgery. So, and also because something like oral contraceptives are used at a younger age, so it has that added benefit of preventing some of the earlier onset, potentially. That's how we would approach this. But the risk is, the mutation is the biggest culprit here. And we have not found something that'll prevent or increase as much as a mutation does. If that makes sense.
Okay. And there may be different options for breast cancer risk because we generally take our recommendations from the NCCN guidelines that many of you may have heard of as you're being followed after you've been had genetic testing. And so with the NCCN guidelines, there is that recommendation for removal of the ovaries, but we don't have that same recommendation for removal of the breast. It really is just an option. So some of these modifiers that Dr. Kotsopoulos has spoken about today, really we could be thinking about in terms of breast cancer risk for those who chose not to have a prophylactic mastectomy.
Exactly. So we see in our cohort, most will opt for oophorectomy, but not mastectomy. So women who are having MRI imaging for their breasts and are considering HRT, this is why it's important to answer some of these questions. Do we need to be taking estrogen only? Do we need to be removing the uterus at the time of oophorectomy? So a lot of these things are still being decided on, but women are having MRI imaging, which is a good thing to catch cancers earlier.
Okay. There's also a question about, and I think it would be both for BRCA1 and BRCA2, if you've had a history of breast cancer, should you still be thinking about your ovarian cancer risk? Is that risk still elevated?
Okay, I see that question. Yes, and as a BRCA mutation carrier with a cancer diagnosis, Dr. Metcalf and Dr. Narod have clearly shown that oophorectomy is strongly recommended to improve outcomes also from your breast cancer. So not only, yes, your risk of ovarian cancer is still there, but oophorectomy and removing your ovaries plays an important role in the treatment of your breast cancer. Dr. Metcalf, do you want to
Yeah,
add?
no,
anything
I
else?
think that you've answered it there. I think even if you've had a diagnosis of breast cancer, you still need to be thinking about your ovarian cancer risk. That's not going to go away because you've had breast cancer or you've been treated with breast cancer. It really has nothing to do with your breast cancer diagnosis. It's a completely new cancer. And you still have a very high risk of developing ovarian cancer. So there's questions about participating. We can definitely send you that information if you're not part of this large risk factor study that we're talking about. We definitely would really be happy for you to join the study. We are learning so much from all of you who are participating.
Yes, please make sure we are continuing to enroll, and we would like to engage your family members, anyone that may have a mutation, to participate, irrespective of your mutation.
There's also another question about breast screening, and we haven't really talked about that today, but we definitely have talked about that in great detail in some of our previous seminars. So I would encourage you again to go back and have a look at those previous seminars, because there is a lot of new data coming out, especially about the use of MRI for breast screening. So please go back and have a look at that if that's of interest to you.
And about your children, I see something about an individual with a mutation. I have a child with a mutation. Is there anything I can do? So it's important to have genetic testing, number one, to know what the risks are so they can continue to speak with their genetic counselors and have their evidence-based recommendations.
And especially in those younger ages, the teens, the 20s, there often are questions like Dr. Kotsopoulos talked about today, the use of oral contraceptives, especially if you have a female child. So those are often the questions that you may want to come back and see your genetic counselor, or if you're being followed in a high-risk clinic or your children are. Those are some of the conversations they may want to be having at that time. It's very age related. And often those are the types of questions that we're seeing at that age about the use of hormones for that particular age group.
I see a question about how the age of the participant, and what is interesting is that Dr. Metcalf and Dr. Narod and I are really interested in continuing to follow our mutation carriers, even our aging cohort. Thankfully, we know we're trying to help individuals not develop cancer, treat them the best way we can. And now we want to follow mutation carriers for other outcomes or long-term outcomes. So irrespective of your age, we want to continue to follow indefinitely. And we're trying to perhaps change our way of enrolling and following up to ensure that we can continue to have some detailed information from you over time. So please continue to participate irrespective of your age.
Mm-hmm. There's also a question about males being tested. Again, it really may depend on if it's BRCA1 versus BRCA2. We know there are different risks associated with those genes, especially when we're thinking about male cancers. Definitely an individual decision. They may want to know about it for screening, prostate cancer screening, male breast cancer screening, but they also may not want to know about it if they're thinking about having children. So that's something, again, another conversation that we could be having about IVF treatment and whether there is the option to have testing done before an embryo is implanted. And again, Dr. Glass talked about that. It's not only relevant for female mutation carriers, but it's also very relevant for male mutation carriers. So please go back and look at that too. Again, it's an individual decision for the males on when they'd like to be tested and what they want to know that information for. But definitely go back and have those conversations with the genetic counselor. The counselors are there to help you make those decisions about whether or not you want to be tested or your children want to be tested. So please go back and visit with your genetic counselor.
So there's one about, so I'm just gonna generalize this one question about HRT use. So again, we think about HRT use around the time of oophorectomy, especially for individuals who had their ovaries removed prior to menopause. So I am not a clinician, and it's important to continue to talk to our gynecologist or your family doctor about HRT use. But usually HRT use is indicated around the time of menopause. So there's no, unless a woman, and again, from a non-clinic standpoint, we think about using HRT to help a woman who has had surgical menopause reach the age of natural menopause and mitigate any of those symptoms that come with early surgical removal of the ovaries and the hormones. So, and there is no screening for ovarian cancer, if that was what the question was right now. So that's why it's really important to have your ovaries removed at the age that's recommended by the guidelines.
Okay, I think that that's the end of the questions.